Start recording. So now it's being recorded. So good morning, everybody, and this will be a Zoom recording with Professor George Dangas, my personal friend for last almost 15 years, or maybe a little more. He belongs to America, and he is one of the topmost interventional cardiologists in the US, based in New York, in Mount Sinai Hospital. He's also professor. He's also professor of medicine in Ashton School of Medicine at Mount Sinai and director of cardiovascular innovation. He has a huge experience of interventional cardiology, and he has been also associated with hugely with American College of Cardiology. And I have vivid good memories when he came to join us in the Indo-European course on revascularization in Amsterdam, which was organized by us jointly with ACC also. And he was there in August 2010 in Academic Medical Center in the University of Amsterdam. So welcome, Dr. George Dangas, and I am Professor Dr. Vivek Gupta. I'm cardiologist in Delhi Apollo Hospital, and working here. I used to work with Professor Alan Crevier, who is the father of Tavi. Unfortunately, we lost him in February 2024, and he was one of the very personal friend. I am still not able to convince myself that he is no longer with us. So, Dr. George, or should I call George or Dr. Dangas or whatever?
As you wish, Vivek. Great to talk to you again. And indeed, I have keen memories of Professor Cribier, yourself, and Dr. Henriks, director of the cath labs at the Academic in Amsterdam, where we had this great conference in Indo-European Intervention Council. And of course, it's a very moving time as a year since Dr. Cribier no longer with us, this legend of interventional cardiology above the heart disease. I'm very pleased to talk to you, not only for this above reason, but also under my current status, 2023-24, president of the Society of Cardiovascular Angiography and Interventions, SCAI, very, very strong with Indian membership, as well as expanding worldwide in a major direction. Very pleased to be the 46th president of the society, originally founded by Dr. Judkins, Dr. Stone, Dr. Soames, I should say, the pioneers of cardiac catheterization, invasive selective coronary angiography. So happy to talk to you about whatever you think you want to discuss regarding the status of interventional cardiology this year.
I just wanted to recall, you say it was done by Dr. Soames, who developed the Soames catheter. And of course, these are the landmark time for the interventional cardiology. And if you recall, we goes from the past to present. If you recall, the first angioplasty was done by Andreas Grundzig in 1977. I don't know, do you have any experience of working with Dr. Grundzig or any chance of meeting with him? If you have, let us know.
No, but I do remember vividly again my presence as a invited faculty, actually the youngest one at the time, 1997. In the at the anniversary of angioplasty in 2007, the 30th anniversary of angioplasty as well, in Zurich, at the auditorium, exactly. The first live case was done. And I do remember meeting the first patient. Apparently, the first patient did great. Even 40, 50 years later, he was still alive, despite having some other lesions, in fact, needing stents or whatever else he needed. He never had bypass surgery. And that proximal LAD lesion, Dr. Grundzig had treated with a balloon angioplasty. It was really fine. So it's tremendously important to think that not only the result was great, but the patient selection by Dr. Grundzig was amazing. Because as we know, a lot of the results of what we do have to do with the patient themselves. And the medical therapy we give them to mitigate the disease, the way they follow up, the way they're motivated to follow up with the doctors and all that. So it seems like all the stars were aligned for this very first patient. And not only there was an acute complication, that was the initial presentation, but the long-term result and the multiple decade survival was terrific for a very, very eccentric proximal LAD lesion that that patient had. By everything we know now, is one of the most ominous diseases for stenosis and for unfavorable outcome. Well, none of those happened in that very first patient. It was a tremendous success.
Okay, that's great to know that. Of course, we lost him in 1985 when that was very young. He was plane crash. It's a charter plane, that's what I know. So moving from 1977 to 1987, when the first stent was done, and that was done by Jack Spule and Ulrich Sigward simultaneously. But Sigward is more known because the publication came earlier from Dr. Sigward, who's a personal friend from Switzerland. So anything which you want to tell about Dr. Sigward? Of course, we have worked together. I've not worked with him, but he has been a part of our Indo-European course. So I just want to listen because now you spoke about Andreas. I want to, to whatever you had relationship with Dr. Sigward, who is still alive, and he keeps coming to our conferences quite often. Yeah. And so what are your experiences with Dr. Sigward and your first stenting?
Well, it's a very, Dr. Sigward, Professor Sigward, I would say, is a very, very distinguished cardiologist from Geneva, from London.
Yeah, he was actually working in Lausanne, I think. He did the first stenting in Lausanne, which is in Switzerland. And I visited that place and I found that the cath lab is named by him, Sigward Cath Lab.
He
worked in London also.
Very soon afterwards, he became the director of the department at the Brompton Hospital, Imperial Hospital in London. He was there for many decades and ultimately came back to Geneva as a professor and chairman until his retirement. The first stent was remarkable. It was a self-expanding stent, the one he did. And he found out both problems. The one, that the expansion may be uneven with the self-expanding stents, and second, that the thrombosis was a real issue. And of course, it was a big achievement with a good acute result, as well as the discovery of how to navigate those problems became very apparent from a get-go. And as you know, we still struggle about not only restenosis, but also the thrombosis effects of the various types of stents.
So as we know that I would just, in 1987 was the year when the first stenting was done. And then Patrick Saraz and other people, they did a lot of studies, plain balloon angioplasty versus coronary stenting. And one of the landmark trial was Benny stent trial, which was published in New England Journal of Medicine in 1993, which established coronary stent as a much better device versus POBA, plain balloon angioplasty. Then we came up with the drug-coated stent, which were in India. They were introduced in 2003. And then, as you told, the restenosis was significantly reduced. And today, as of now, there is no plain balloon angioplasty. It's always drug-coated stent and not the plain bare metal stent. I would like to spend next 10 minutes with Professor Ella Cribier and structural heart disease intervention with Dr. Professor Ella Cribier, maybe 5-7 minutes, because he was very close to me. And let me introduce that I worked with him in 1996 to 97, 98 for almost 2 years. And I was very close to him personally. And there are 2-3 moments which I want to recall, George. One was that when he was driving in a car, the day one, when he took me from the railway station to the hotel, and then from the hotel, he was going to the cath lab, Charles Ecole Hospital. He said he has 2 projects in mind. One was that putting a aortic valve without surgery, and the second was doing a bypass without surgery. That project he did not finish. He had another project of doing a percutaneous bypass, venous to arterial, percutaneously. I think this project he could not finish, but that was also one of his passionate project. So with Dr. Cribier, 96, 97, 98, and I want to give you a small historical perspective. In 98, it was not born. It was born, the first in-man implantation was done by him in 2002, and that was April 16. But before that, the 2 things which I want to highlight during this conversation is that when he was searching for the sponsor, because 94 he started looking for a sponsor, and he was not successful till 1999 to find a sponsor who can sponsor the project of innovation. And till 99, he had received a lot of emails, which I also shared. Medtronic Edwards, they completely refused to sponsor the project. They said, this is crazy, this is impossible, and this is just forget about this project. So then he made his own company with Martin Leon. You know, you have a good friendship with Martin Leon. He made a company by the name of Medicorp or no, something else. And with Martin Leon, and then they started with the Israeli, they started prototype, and then they did minimal experimentation first in man. I would like to you give more highlights about Alain Cribier. He's a very personal friend. I know you are very close to him also, but you are sitting in USA and he was in France. So give something about Dr. Cribier and about this structural heart intervention, which is transcatheter aortic valve implantation, which is done non-surgically.
Yeah, well, as you said, Alain was a talented innovator. He pioneered the balloon aortic valvuloplasty, recognized the restenosis problems, and targeted the TAVR, and that's very, very successfully. And as you say, with the joint consortium with Mori and others, they were able to start up the what we all know the Sapien family of valves. That was then again followed by another cell. There's always a balloon expandable versus self-expanding situation in any type of stent. So that's why originally I said the coronary stents was started with a self-expanding, and then very soon after we had the balloon expandable, they said here they kind of a little bit the other way around, but ultimately we end up having both balloon expanding and self-expanding valves in our armamentarium, and that is really great. And clearly, again, as I said about the Grunzig's first patient, the patient selection had a lot to do with the success of the procedure and averting, I would say, the naysayers and averting the competition. What do I mean by that? We first started by not about the best cases, but the worst of all cases. Those were inoperable palliative procedures and all that, in order to have a good clinical criterion that was really those were the salvage cases. And after they had good success and proof of principle, we moved the field in a regimented way to the high risk, then to moderate risk, then even to low-risk patients. So this took a long time, and exactly why? Because we focused on the proper patient selection. Let me just say again that none of the valve therapies or any therapy is of any use if we try to go gun-ho in an unselected way for everybody who happens to be passing by our clinics and hospitals. Patient selection is of utmost importance, and that's what we saw again here. And for that, I would say Dr. Cribier was a real master and really appreciated worldwide throughout his career and life.
What I want to share, the first case from India, TAVI, was done by Dr. Cribier. And this was the patient who was my patient from Delhi Apollo Hospital. And we took him to Rouen because it was November 2011. He was a frail 86-year-old male, a gentleman, and a rich man who could afford to go to France for the treatment. And at that time in India, it was not available. India, it came in something like 2016 or 18, the first case was done. And after that, we have a lot of progress. But the first case from India was done by Dr. Alain Cribier. And that time, November 2011, I was scrubbed with him. And I saw his speed, 40 minutes exactly in 2011. He finished the procedure. It was the Edward XT valve. Of course, these are all balloon expandable valves. And within 40 minutes, with a conscious sedation, there was no general anesthesia. He finished the procedure and we discharged the patient the third day. This patient was treated by him. So we had then at that time, I did not know the techniques. So he came about half an hour later on in the late evening, sitting in the computer room. He told all the technique, explained to me. So I had a great privilege to learn directly from the master how you have to go and how to do the planning of the valve and so many other things. So, of course, he's no more with us. He had a sudden cardiac death. And I would like to give you a small thought process. He had, of course, you know, that he had a stents few years back. and this time he had a sudden cardiac death. He took lunch in the afternoon in the cafeteria, and he was doing well. And he was programming to do another workshop, TAVI workshop in Rouen in May, and in February he sent a lot of messages. He was sitting with free at home, and his wife came from the Paris, and he found him. He's no more. So this was sudden cardiac death. His ejection fraction, which I was aware, I may be wrong, was about 45 to 50%, but he had a stent and he had a MI. So I personally feel the guidelines have to be really modified, because any patient, we cannot do AICD, automatic implantable cardiac defibrillator, unless you have ejection fraction less than 35. These are guidelines. Sometimes guidelines misguide you. If he had a AICD, he would have survived a sudden cardiac.
Another not comment any further in any personal details, and we all admire Alain as a and as a legend, and I think probably we move on to some other subjects on that.
One more thing, sir. You had a talk of renal denervation and you had a talk of bifurcation. So I would like you to spend some 3 minutes or 4 minutes for especially the young cardiologists, because this seminar is also this Zoom. I want to know, you had spoken about during this conference in Jaipur, where we met recently, organized by Eternal Hospital. Dr. Samin Sharma was a good friend. So you had a very nice talk. So can you just summarize a few points about the left main bifurcation?
Yeah, of course. Bifurcation is one of the very interesting subject of mine. A lot of research and case presentations, a lot of teaching about it. I have a special Bifurcate app at Mount Sinai, pioneered by Dr. Kini and Dr. Sharma. It's available for free to download at the App Store. That's how anyone can actually ask a question and find an immediate answer regarding bifurcation, the various steps and all that. The many techniques in bifurcation. By the end of after many studies, we found out that the simplified techniques may be better. Make sure you don't lose a side branch. You don't have to go crazy with a perfect result. Try with a provisional stent in the beginning. And, regarding the two vessel dedicated double stent techniques, these are more for when the side branch is large, has extensive disease or significant calcium. Debulking has a lot to do with an optimal expansion of the bifurcations, and the many techniques. We don't have a very clear results, comparative results about which one's the best of the best. I think to me the best is what what everybody knows better. So try to identify the indications for a two-stent technique and try to be efficient with one of those, and use a lot of intracoronary imaging to optimize the results in the main vessel, particularly proximally with the proximal optimizations, etc. SCAI has pioneered a bifurcation club in association with all the different bifurcation working groups around the world.
Yeah.
And we encourage everyone to join the society and participate in the functions of the Sky Bifurcation Club as well, and be engaged with the different case presentations and discussions around that and through the web.
Thank you very much, Dr. Dangas, for talking to us. But before we finalize this talk, I would like to give you a small message, how to remain young like you, how to remain happy like you, for especially the cardiologists who are always under stress of having the best results and the best outcome in all those even complex patients. So I've been watching you. You are so young and handsome. And so I would like you to give a small message to the young cardiologist, how to prevent your stress level working in the cath lab, so that people get more and more life.
Well, I think, you have to spend a lot of time in the cath lab. What we do is has a lot of stress and impacts patients immediately. I think everybody has to kind of develop a collegial atmosphere with the environment they are, and there are many people around. And not obviously our colleagues, our associates, always exchange ideas about junior and senior colleagues all the time, even now, every day. That's what we enjoy and I enjoy the most. We train new physicians. At the same time, now we have all these new things. We have nurse practitioners, physician assistants, the cath lab staff, the nurses, technologists, even the people, the patient liaison, people who receive the patients up front and discharge them later. They all want to know about what is it that we do, and they keep engaged and ask questions, give them some photos of the procedure, develop an atmosphere that everybody learns from us. And at the same time, they help us in our day-to-day things. So we don't have to do everything ourselves. And so we don't have to really stress too much out, because everybody is working together towards it.
Teamwork.
Run around and distribute reprimands to everybody, but go around and distribute accolades and congratulations instead, and give thanks to everybody, because whatever we do is never us, it's never me, it's never you, it's never an individual. It's a whole team we have to thank, and that's this approach. I think gives. I think it gives a little bit down regulation of the stress level to a certain degree, and try to, as much as possible, settle the family and professional goals to something that is enjoyable as well as sustained. These are my 2 cents. And thank you again, Dr. Gupta, for giving me the chance to address my colleagues in the Indian subcontinent. My best regards, and I thank them always for their participations in all the conferences in person, via the web, and their activities at TCT, SCAI, with ACC, and all the other organizations that we all participate. I know we also see each other at ESC and AHA. They always have a lot of participations from India. That's why I think you're doing so great.
Yeah, the last thing I want to tell you, that in our cath lab, what I try to do, I try to ask the patient to sing a song while I'm doing the procedure. So this helps the patient and relieve the stress level for ourselves. I started doing one thing which my sister said, no, don't do it. I started singing myself while I'm doing the procedure. It was, my sister said, somebody watching you, they will say he's a non-serious doctor, so don't do it. Try to let the patient sing is okay, but not for yourself. Thank you very much, Dr. George. I'm finishing the recording, but I would like to speak to you a little further. Just stay with me. I'm just stopping the recording. So it was Dr. George Dangas, who was one of the pioneers of interventional cardiology. And I am thankful to him that he gave me some precious time from his working schedule to talk to us about interventional cardiology. We will meet soon with him physically, and then we will do. Thank you very much.
All right, Dr. Gupta, great. Thank you.
I just want to speak to you for a minute. Please stay with us.
Yeah, I'm saying.